Welcome to the Onco PT podcast, where you'll learn from oncology experts, practitioners, and patients to help you on your journey to become a confident and competent Onco PT. Here's your host, Elise Cantu.
Hey, Onco PT, and welcome back to this episode of the Onco PT podcast. One of the things that we're doing this year in 2025 on the podcast is we're doing more of these kind of debriefs of, okay, one of our audience members or one of our amazing community people has gone through a course or a conference, and we're bringing them onto the podcast to talk about their experience. One of the things that I love about this series that we're doing is it's nice to know what you're getting yourself into. And I think this topic today is especially pertinent to that, because when I tell you the importance of becoming a CLT was impressed upon me as I was finishing up PT school and as I was going through my clinical rotations, but the explanation behind why I should become a CLT was maybe a little lacking. And so I didn't really know what I was getting myself into. It was a very positive experience. But I'm bringing someone on today who is going to talk all about her recent experience going through her Certified Lymphedema Therapist training and kind of the behind the scenes of what was her experience like. And if ultimately you're discerning if this is the right move for you, then hopefully this will help you make a decision in the future. So Dr. Kelly Martin, you may know her. You may not know her, though, because she is one of the amazing behind-the-scenes persons here at the Onco PT team that we so adore having on our team. She is the brains behind our research roundup that we do inside of the Onco PT specialization community, and so much more. Also is going to be a featured speaker at the Cancer Rehab Community Conference later this year. I'm just saying, like, if you don't know Kelly yet, you're going to get to know her very, very well soon. So Dr. Kelly Martin, welcome to the Onco PT podcast.
Thank you. I think it's been a long time coming.
It has been a long time.
I think the last time I was even on the podcast was probably last fall.
I think so. I think we did like a little research roundup. Yeah. Mm-hmm. Yeah. It was overdue, my friend. So welcome back. Would you mind reintroducing yourself to the audience, please?
Yeah, absolutely. So my name is Kelly Martin. I am a physical therapist, and I am currently now located in Virginia. Originally, when I was last on the podcast, I was in North Carolina practicing and have made a move in the new year to join at UVA at their cancer center as well as their breast care center. And so I'm really excited to kind of fully delve into the oncology rehab world. And so I've been working now for coming up on surpassing 6 months, which is even wild. And then kind of pertinent to the podcast episode is coming up on now 3 months as a CLT or Certified Lymphedema Therapist.
So exciting. So many new things over the past 6 months plus with you on our team. So let's take a step back real quick. So if you are maybe brand spanking new to oncology rehab, what the heck is even a CLT, which we defined previously, but let's kind of set the stage for what is a certified lymphedema therapist, at least in your experience and now as a CLT, Kelly?
Yeah, so certified lymphedema therapist, I feel like it got thrown around maybe once or twice as a PT student. I always joke with some of my patients that I treat for lymphedema specifically, in that when I was a PT student, I knew maybe two things about lymphedema. One, that we had a lymphatic system, and two, that we needed, when we did CDT or complete decongestive therapy, which is one of the mainstays of lymphedema treatment, that you needed to use short stretch bandaging that had a high working pressure and a low resting pressure. That's what you needed to know to answer a question related to lymphedema on your board exam as a PT student. So that's what I memorized. And then you enter this interest into oncology PT and you hear that word thrown around a lot more, and you're like, oh, lymphedema, how do you treat it? When is it prevalent? How do you monitor for it? What do you even do? Is exercise helpful? Is it not helpful? I think sometimes there's a little bit of a scare tactic about what if lymphedema is not managed, and they show scary pictures of really big limbs and all this stuff. And so there's some scare tactics in it, and you're like, what the heck? What do I do? And then you get into oncology and you're like, okay, this is definitely a considerable diagnosis for people. And it's not just breast cancer, it's a lot of other cancer diagnoses that people who may not be as familiar with oncology and lymphedema, they don't realize, prostate cancer, any of your abdominal GI cancers, your gynecological cancers, the gambit. If it affects the lymphatic system and they have lymph nodes removed, they have radiation in an area where lymph nodes are there, there's an opportunity for lymphedema for someone to be at risk or for someone to develop it. And so then
Bingo.
we kind of have to remember to screen for that. And ask the right questions to make sure that it's not something to be considered, or if it is, let's intervene right now, because the quicker we intervene, like many things, the quicker we intervene, recognize it, the better off a patient does. Their outcomes are way better, the prognosis is way better, and a lot of times their management strategies can be way better as well. And so I think then it kind of falls in nicely. It was like, okay, well, if I'm going to kind of come into the onco PT world now in 2025, like really be in it, okay, I need to really consider getting my CLT.
Before you started your new position, before you really started, considering, I think I need to go through and get my CLT, what was kind of your understanding or your attitude towards CLT school?
I think originally I knew that it was a part of oncology rehab. I almost felt like it was like one of the most unglamorous things in rehab. I think some of that comes from the scare tactic of like, oh, like
Understandable.
I almost equated it to like wound care. And that's not what it is. I mean, yes,
Right.
wounds could be involved, but it's not the end all be all of what lymphedema management is. And I think I was kind of like, well, I don't want to do that. Like, that's not why I came here. That's not what my interest is in. Do I really need this? So it wasn't really on my radar. And then when I was transitioning into my job, funny enough, originally I thought I was going to go into acute care in the position to start. And then they asked me, like a week before, was like, hey, what if we onboard you in we're going to do this differently. What if we onboard you in outpatient? And that would start with outpatient oncology, which we know you really, really like and you're very interested in, because I had applied for an outpatient oncology position with them and I did not get it. But they enjoyed my interview, that they wanted to offer me another position and potentially work into oncology as their program grew. And so for me, it was like, all right, this may mean my original, I guess, brain was saying, oh, I'm going to be in acute care and I'm going to work my way to oncology. And then it was like, no, thrusted upon me, hey, you're going to start in it. And I'm like, all right, well, I'm fine with that. And then my role kind of completely transitioned to all outpatient oncology. So I think it was more so that transition in what I expected my job to be, that I was like, okay, maybe this lymphedema thing is really important. And if I'm going to split my time between our cancer center, which we see our stem cell transplants, we do see some head and neck cancer. We do also see some of our prostate and gynecological cancers, and we're expanding, which is exciting to be a part of. But then half of my practice is then in our breast center, where I think lymphedema is the most common, most well-known diagnosis that comes with breast cancer. The risk is there. People know about it more. And so that's really where it was like, okay, I need to really consider this. And then my job actually partners with the school that I did my CLT training at. And so they were like, it's paid for if you want to do it. And I was like, okay, well, I wouldn't mind. It's not cheap. So if you're going out to do the course on your own and not through your job, or if you're in terms of considering your continuing education allotment, it is a big investment. I think it's about $1,200, $1,300 to do the course as well. And I think that's pretty standard across all of the mainstay programs like Norton, which is where I did my training, or Close, and some of the other ones that are out there.
Mm-hmm. Mm-hmm. Yeah, I think price-wise, they're about the same generally. Now, I haven't, I don't have a spreadsheet where I have all the numbers in my head. So my next question, Kelly, is at what point was there a tipping point where you said, okay, I'm going to do it now? But it sounds like the, hey, we'll pay for it was quite a great motivator to be like, okay, it's time to get this done. But was there anything else that made you say, it's time? Like, it's time for me to do this. I'm going to go all in on it.
Yeah, I think that's a great question. I think what really flipped for me, I don't know, I always, when I think about that in my head, I'm like, well, what made me decide to do it? One being, okay, a lot of my patients that I'm going to see are going to be dealing with this or are at
Mm-hmm.
risk for this. So it's like, okay, I need to be knowledgeable of it and I should be able to intervene for it. And I also think that it's just me and another therapist. So if we think about lymphedema management, and when I was starting and being trained, the other counterpart for me, she's this lymphedema therapist, and she's like, yeah, like people drive hours. The gaps in care for people to have access to this treatment
Right.
is few and far between. People may wait months to years to be seen for this. And I was like, okay, I think a lot in my heart when it comes to rehab, and it also kind of stems in like go where you're needed too.
Mm-hmm.
Even if it's not your favorite thing, or even then, I think my opinions of what does it mean to be a lymphedema therapist, we're still like thinking about wounds and not wanting to be with wounds, and like thinking about every person that I interact with would be very complex and have lots of comorbidities, and there are patients that are that, and they're fun to work through too, and it's really sometimes rewarding to get them what they need. But majority of who I treat, and like especially like at the breast center that I'm at, majority of the people I treat are probably, surprisingly enough, they're in their 30s, 40s, 50s, 60s maybe, and they're very active, and which is, I mean, my bias. I want people to be physically active after their diagnosis. Right. There's no reason that they can't get back to what they love. I want to be a facilitator of that. And sometimes lymphedema can get in the way of that. And so right. I think for me, that's where my mind really shifted and was like, okay, this skill set will help me bridge. It is, for some people, it is helping me bridge the gap between what I really want to do with these people, which is get them back to exercise and training and activities and hobbies that they enjoy. This is a barrier for some people. Sometimes it's even the fear of being at risk for lymphedema alone. That's a barrier for them to be active. And it's like, no. We can break that barrier very quickly, right. Which is very rewarding, because I think they're afraid. Again, the scare tactics that got me thinking, oh, I don't really want to do this, are the same scare tactics sometimes that are used to be like, well, if you don't manage this is what your arm's going to look like. Yeah. And it just like can be traumatizing. And then there's a time and a place to be blunt with someone and say, yeah, that is totally that can happen. Totally. But I would say 95, and I tell my patients, I'm like, 95% of the patients I see don't look like that at all. They don't. It's just, that's when it goes completely uncontrolled. And tell them, like, you're in the right place. It's going to be controlled. So that's not going to be you. So I think that's really where my mind shifted and was like, okay, like this is a barrier to what I really want to do with people. And so I need to have the skill set to break that barrier, or I can't get to what I really want to do anyways. So let's tackle it.
Nice. So you mentioned previously your workplace has partnered with Norton, which is the program that you went through. That's also what I went through way back when I got my CLT in 2018. So came out of school, I mean, like fresh. It was June after I graduated in May. And so I'm giving this context to the listener because I went through my CLT program pre-COVID. And I understand that in light of COVID and like all the stuff that was happening with that, some programs have changed kind of the approach that they do. And so I want to know, Kelly, my program so it was 135 hours total, and we did 35 hours of ahead of time, like video modules before you actually went to the 10-day, 10-hour days. That's where the 100 hours comes from. That we did for our program. So what did your program look like when you took it in spring of 2025?
Yeah, I started it in February of this year and finished, it was like the end of February through the first weekend of March. And so they didn't have any offerings near Virginia. So I actually ended up going to Charlotte, I drove down there and took the course there, in terms of getting it done sooner rather than later. And so it was kind of nice how I thought, in hindsight, like it was kind of nice. I started in January, and so I was already I was being trained by the PT that I work alongside. And so I was seeing patients that have lymphedema, and we were talking a lot about, what does that look like? And, monitoring lymph volumes, and how we have our lymphedema surveillance clinic has the bioimpedance and long-term garments, and how do you select those? How do you measure for those? And so I was already getting some practical experience with understanding lymphedema, and reading the clinical practice guidelines that the APTA puts out, and kind of being in the literature a little bit. So it was like little exposures. And then the course prep itself, it honestly sounds exactly how you did it. Is we had 35, 40 hours of module work that went through, the anatomy, physiology, types of garments, CDT, exercise, all the elements that involve complete decongestive therapy, and then long-term, the maintenance phase of lymphedema management. And I have to say, I wish they would update these things. I know that costs money, but I swear the videos I was watching are from the 1980s. They're so old. They're so old. You can't speed it up. It's like off of VHS. I was like, what am I watching? I know lymphedema has come a long way. And it has a long way to go, but has come a long way from these videos from the 80s.
Yep.
That always made me chuckle every time I was watching them. And so the prep work, as I was working up to, full time, and I didn't start seeing people by myself in terms of seeing patients with lymphedema or at risk. I didn't see them by myself until after I finished the course. I was completely partnered, but I was leading. As I was learning, I was kind of leading different parts of it, whether it was educating, doing the circumference measures. So I was getting to practice a little bit.
Nice.
And kind of talk through things, which I thought was really nice. So then I was kind of, going through the modules on my own after work. And if there was any downtime, I would do a little bit of some of the prep work. And so it was nice to be able to I tried to take the prep work while I was onboarding and put it into practice, whether that was just educating or talking about it. And so that kind of made it stick a little bit better, because then when you drive down there and the first day, of course, they scare you and they're like, it's a pretest. It's not graded, but it's a pretest. You need to see how much you remember from doing the modules, because, when it comes to continuing education, obviously you pay money to be there. And most people, unless it's some, very specific bad reason, everyone's going to pass it some way, whether it's the first time or we had someone who got, they're pretty good about, extenuating circumstances. Someone gets sick or an emergency happens, and they jump into another course. And so we had someone come from another course offering for part of the program towards the end, because they had gotten sick. And so you go down there, you take the pre-test, and then you start kind of reviewing some of the things that were in the modules and trying to build on them as well, because we already did the prep. You should have done the prep work. So to kind of rehash all the lectures again would have been kind of overkill and a waste of time. So they were kind of starting to build on the foundational stuff we had already prepared for in the modules. And then a lot of it was really learning the practical skills like manual lymphatic drainage and compression wrapping, and doing a whole, building through all the different techniques for manual lymphatic drainage, all the different ways we wrap the arm or the leg, and practicing it. It was like, all right, you're going to do the sequence. And then it was all kind of like lab. It was like, all right, you're going to do the MLD sequence. Now you're going to wrap that limb, and you just rotate through everyone. So you had people that were taller, almost like PT school, honestly. You had people that were taller than you, shorter than you, larger than you, smaller than you, long arms, short legs. And so you kind of got the chance to practice a lot of reps and critique yourself. That was like one of the mainstays in their course, was like, you should be able to, your bandage is never going to, you always aspire for a perfect bandage, but you want to be able to critique what you've done so that you can keep getting better. Because when you go out there at first, you're not going to be good at it. You're going to struggle. Yeah. And different patient scenarios may cause you to struggle. So it's never going to be perfect, but if you can continually critique yourself and make yourself better, it all works out. So it sounds really overall very similar to how you took it. And maybe, I don't know how they would have done it during the years of COVID. It may have, a lot of maybe Con Ed was on pause, because I don't really know how they would have done the in-person portions, or they did smaller groups, who knows. But this like hybrid model in terms of preparing and then going for a super long course. I don't know any other continuing education course that's 10 days long. That was probably the other thing that was big for me, was that the course was it was a long 10 days
long.
And 10 hours. Like you woke up, you went there, you went home, you ate dinner, and then I went to bed. Like I didn't have time to really, you had to be immersed while you were there, because I didn't have time to study. When I went home, I was exhausted.
No, so I took my course in Nashville because that was kind of the closest. Again, this is 2018, so it's been a few years, but it was the best option for the time that I needed, and like close-ish enough. And it really was like, I checked into the hotel every morning. I would drive to where the course was being held, would be there for 10 hours, drive back to the hotel, and eat dinner, and then basically go to bed at that point. And I agree, like I kind of had to immerse myself in that and just know like, this is going to be a grind while I'm here. But I really do feel like that was really beneficial for me to just be so absorbed in it. And I also really liked, I'm curious on this, Kelly. So I think my cohort was maybe about 12 to 15 people. I don't remember the exact number. I could probably go back and look. But it was really cool because you're in that course for so long with the same people. It was a really cool experience to then get to, like we're practicing with each other, and we're, we're constructively critiquing each other and whatnot. But really being able to just like get those repetitions in and to get the feedback from others so intensively, so many times over that 10-day period, I feel like really sets the CLT experience apart from any other continuing education course that I've taken so far. Because I feel like in a lot of CEU courses, it's very lecture heavy. And then you might have a little lab where it's like, 30 minutes, like here's a couple palpations or, like manual techniques, practice them. Okay, sit down. Now it's time to move on to stuff. Whereas my program, and it sounds like your program too, it was like maybe a little lecture and then it was just manual. And so again, reps on reps on reps, to really get the MLD down, the bandaging down, the foam application too, which I understand that's like a really, I don't know how big that is in some of the other programs. It seems like Close and Norton. So Close School and Norton School, very, very similar, like very, very similar components. They both stemmed from like the same lineage when it comes to lymphedema. I don't know how much the foam plays into other schools, but like Norton, it's foam. I literally was cutting some foam for a patient earlier this morning. And so like getting to practice that again and again was a really transformational experience for me.
Yeah, I laughed because cutting the foam was like so, it was always so hard. Initially, it's like you were just struggling, and then you put it on, you're like, oh, I think it sometimes just goes to show you put the piece on them, you mark it like, and you look at the sheet and you're like, okay, this is how I'm supposed to cut it, and then it just never. Sometimes it just did not turn out that way at
Yeah.
all. I was like,
Totes.
that I just butchered that. Oopsies. And then like, yeah, that was the one thing that the therapist I worked with, she was like, you're gonna have to get yourself a good pair of scissors. Like, you need to go to the arts and crafts store and get a good pair of scissors. And I carry my good pair of scissors. I've never had to buy a good pair of scissors, but I carry them in my backpack
You
all
carry your
times
good pair of
now,
scissors. Yeah.
all the time.
Yeah.
And I cut foam like a queen now, and I can bevel now, and all these little nuance
Oh
things.
my God.
But I swear I struggled in the course so much. I was like, this is, and then I always joke with my patients, I'm like, yeah, this part of it's kind of like arts and crafts. But it makes such a difference. And I think in some ways that's where like having some experience and then going to the course and learning it in one way and thinking about it like this is the gold standard is interesting because where I currently practice, we were kind of like, okay, if we're gonna do CDT, it's like, all right, is this person experienced or not? We've done the assessment. What does their skin feel like? How much has their limb volume changed? If we have something to compare it to, and there's other courses that people will take on lymphedema management, whether that's other CEU courses, that I feel like a lot of times it's someone's like, what's the least amount of stuff we can do to get the best volume
Interesting.
reduction? Whereas in this course, and I see that in clinical practice, but then in this course, it's like, okay, I'm here for 10 days. I need to learn it this way. One, because it's important. And two, because this is how they're going to test me. Even if I disagree, or I'm like, well, do you need the foam? Do you really need it? If the patient, there's different models of how lymphedema gets covered and how bandaging supplies get covered. And so I think that is really based on what model each provider is in. Like, I'm in a big health system model, and it's kind of all of our bandaging supplies. It's actually quite nice. All of our bandaging supplies are part of our just budget. So like the patient doesn't now, even though Medicare covers those things,
right
now, the patient doesn't ever have to worry about that. We have everything we need. We have foam, we have Comprex, we have the stockinette, we have all the different bandages sizes, we have all of the finger wrapping stuff. We have everything, which is great. I know that that's not how it works in other models.
Right.
And so in some ways, this thought of like, I've seen it done where we do all of the other, compression wrapping, but we don't add foam at first. We see what happens with the first reduction. And then we say, okay, maybe we need to be more aggressive. How does someone tolerate the compression, just the bandaging alone? Because I think, cutting foam and then having someone wrap or caregiver wrap with foam, I mean, it's hard enough for us to do it. And of course, it's gonna, if you need your patient to self-wrap a little bit, then you're adding another variable of challenge. Are they able to do that? Do they have help to do it? And so sometimes in practice, I go without foam at first. What's the least amount we can do? See what happens. And then if I need to add foam, I have it right there. I'll do it right away. And so I think in some ways, kind of being, critical of, okay, what are you learning? Here's the gold standard. You're in this immersion moment. You need to do it this way. But then also when you come out of it, okay, this is the standard. I need to aspire to that as much as possible. But then when all the other layers get put into, patient care, and this is the textbook, this is my patient. How do I divert sometimes? Because that's what I have to do. But I can still do a great job, and a limb can still get smaller. And then all these things. And so I think that's really important. I think that's something big that I kind of reflected a lot on after getting out of the course, coming back to clinical reality, and was like, oh, okay, well, wait a minute.
Okay, first of all, I love the coming back to clinical reality after the immersion in this course. Let's take a step back, Kelly, because this is a really, really important aspect of, I think, when we go to conferences, when we go to courses, conferences and courses are based on the evidence, as they should be, right? And hopefully it's the latest and greatest so that we can learn and better implement care to help our patients.
Mm-hmm.
We all know, also here at the OncoPT, that it takes approximately, on average, 17 years for research to come out before it's actually put into implementation. And some of this is based on, just the barriers that be when it comes to, publishing research and whatnot. But a lot of times in the research, especially in cancer rehab, it is very much best case scenario of the patient was able to come in, the services, the PT was covered by the academic hospital that we're in, etc. And so it's taking out some of the barriers or the maybe obstacles that patients have to deal with in the real world as far as like, this is how OncoPT works in the real world. And dear listener, please know, it probably looks different for you than it does look for me, right? I'm in Fort Worth, Texas. Kelly is in Charlottesville, Virginia. There are all kinds of individual barriers, but also systemic barriers that we face in oncology rehab that we have to consider. It may not work that way for our patient. And so what Kelly is talking about when she's talking about gold standard, if you're not familiar with this, is that when you go and you become a certified lymphedema therapist in your CLT course, you learn the gold standard of a patient comes, if we are doing the intensive phase of lymphedema therapy, complete decongestive therapy, they are coming to the clinic 5 days a week, or maybe 4 if you really have to swing it, 4 to 5 days a week. And we are doing MLD and we are doing bandaging. And and understandably, I understand the reason why they have it set up this way of, you come in for this intensive period, it's a few weeks long at the most, and then you transition to more of the maintenance phase where the patient isn't coming in as often and whatnot, and they're doing more of this on their own. Amazing. Great. That is gold standard. The actuality of how it works often does not look like that. And I think a lot of clinicians, when they first get out of the CLT program, are grappling with what you've just talked about, Kelly, of the clinical reality versus the gold standard. And I know that it exists in other areas. I don't know that it exists as starkly, like in stark difference, as it does in lymphedema world.
Yeah, absolutely. 100%. I couldn't agree more on that. And I think I even grappled with that I was like, wait a minute, like if I'm going to go back and do this work, like I need to be seeing my patients 5 days a week. Like, and I think it pushed me to think deeper of like, well, how do I make that feasible for someone? I mean, I've got patients that come from, some of them come from 10, 15 minutes away. Some of them come from like 3-4 hours away.
Yeah.
And I'm the only lymphedema
Yeah.
therapist. We're the only two that they can see. And it's like, okay,
Right.
well,
Right.
am I going to make you, okay, when I think about that and I break that down, I'm like, all right, if I'm going to tell them 5 days a week, that's the gold standard. That's 5 days a week. Okay. Well, are they working? Do they have to take off of work? They have to travel.
Yeah.
They have to pay for gas. They might have to pay for lodging. Are they a caregiver? Are they going to pay for childcare?
Right.
You could start the gambit, and it's like, okay, well, how are we? This was also kind of, I grappled with this, and literally, I texted the PT I worked with, and I said, at some point, we need to like sit down and have a debrief about this course because
yes.
I'm just feeling some type of way of like, I feel kind of conflicted, but I'm also like challenging the fact that like, yes, there's a gold standard, but can we be more efficient with what we have? Like, do we really need 5 days a week? Could we get away? Do we get the same? Like, let's compare like treatment. Like if I treat you 3 days a week versus 5 days a week with the same interventions, can I get the same outcomes? ? Those kinds of questions that I think, a lot of research also goes into with other physical therapy interventions. And So immediately it was like, we need to sit down and talk about this. And I think another layer for me grappling with it is the medical center that I'm with is there's other therapists who are CLT trained, and there was a lot. I kind of came into talks about being a lymphedema center of excellence, and so
That's right. We were talking
really,
about this
really
off air.
wonderful,
Yeah. Yeah.
awesome. Like I'm in a really great spot and environment. The cancer center that I'm at is a comprehensive cancer center. We do it all, and now all of a sudden we want to be this lymphedema center of excellence.
Mm-hmm.
And I'm kind of
Mm-hmm.
coming into this like learning about it and being a part of it and understanding like where are we at in this process. And then I go to this course and I'm like, oh wow, I think we're like really far from that because I've not even,
Yeah.
I don't see the gold standard. That's what's been claiming right now that often.
Mm-hmm.
And then it's like, well, no, that's just clinical reality. And
Right.
I'm like, well, okay, if I'm highlighting these barriers as why someone can't come into the gold standard, like what can we do to facilitate that? Can social work be involved if they need to? Can we get them gas cards? Does social work need to work with them about going on short-term disability? Like, how can we, all these other layers of like, how do we make this possible?
Yes.
How do we,
Right.
it's not that we can't
Right.
do the gold standard. We know the gold standard. We all know
Right.
it. And it would be great to do it. But like, okay, how do we also know the clinical reality, and how do we,
Right.
is there ways for us to meet in the middle? We treat our stem cell transplants at our cancer center, and it's a long process, and so they have social work very actively involved because it's already known to be a long process.
Right.
And if they need gas cards, if they need help with lodging, some of those resources are available. And I'm like, okay, well, can we take that same model and apply that to our lymphedema population? If we've got someone coming from 3 hours away, and I could do this treatment intensively in 3 weeks, 5 days a week, is there a way to do short-term disability? Is there a way to have lodging for them? Is there a way to get gas cards for them so that they can make this happen? Because it's not that people don't do that because they're not motivated to do it. People come. That's one thing about the oncology rehab population I have really discovered. Like, they are so grateful for the care they get, and they will do it. They will do it. If I tell them it's really 5 days a week, they'll figure it out.
Mm-hmm.
If they need to, they will do it.
Right.
It's just, it's really remarkable. So it's like, it got my wheels turning about, okay, well, what are we doing in terms of being a center of excellence? What does the center of excellence even mean? So then I start going, it just opened up a lot of doors of like, what does that even mean? Because I didn't know. I was just kind of coming into it new. And so then going into the literature of like, what makes the center of excellence? What are the qualifications of that? And there's lots of layers into that. But one of them, conservative management involves lymphedema treatment, and that's us. And so it's like, okay, well, how do we optimize us? And so what does it take? Do we need other resources? If we need those, we need to advocate for those.
Well, and I think it's not if we need other resources, it's what other resources do we need? And I think because again, we've had this conversation before off air, but I really appreciate, because for the audience member who maybe is not familiar, the Foldy Clinic, which is in Germany, is like the lymphedema clinic in the world. Like, so much of what we know has come out of, or at least, directly or indirectly. And so how they structure the Foldy Clinic, my understanding is, patients are there, like Kelly is talking about, where they are there, like living in their institution for that period of time when they're undergoing, intensive decongestive therapy, etc. But they have things set up to do that. Like, they are living there, and it's a complete whole body, whole health intervention that they're working with, as far as, yes, they're doing the lymphedema treatment, but I think they're also working with exercise and nutrition and all these other things. And so even in that model of like, this is the gold standard, there are other services that are having to be incorporated because we know, I say we know, I'm looking at Kelly. We know that lymphedema, there is an inflammatory component to this. And so of course it makes sense that we bring in nutrition and making sure that our diet is good. And then we're exercising and so much more. I don't know. And I say this like, I believe we can accomplish anything. I really do. We cannot do that on our own as lymphedema therapists on our own in the wild. It's not,
Yep.
if we need other services, it's whatever other services do we need. And I think the best model that we have for this is something that Kelly has already brought up, which is when a patient goes in for a stem cell transplant, they're there. And, in my area, when patients are going to get a stem cell transplant, most commonly they are going inpatient in the hospital and they're there for, a few weeks and then they leave. But a lot of them, especially if they're like really far out of town, they have to stay in the area or like be close to a major medical center that can handle that acuity for like 100 days or something after they finish. And so that kind of support, again, I think we have a model we can look to in the United States. It's going to take some creativity to make it happen. And it's going to take that inclusion of other services like Kelly is talking about. Gas. Do we need to pursue? Maybe I love the idea of short-term disability. Managing care. Are they a caregiver? Are they caring for a child or another family member or whatever that is? Housing during this time. There's so much that I think we are not equipped and we are not implementing here in the United States to make the gold standard we learn about feasible in clinical reality. And I love all of the ideas that you have mentioned and more, Kelly, about like, truthfully, how do we bridge gold standard textbook with clinical reality? It's through that Kelly is talking about here.
Yeah, so it got my, I think it's a double-edged sword. It's so great to have, a different experience than take a course and then grapple. Like, even though in the moment it's like, well, I am having a crisis and what am I doing? And you think, I always say a lot of times learning experiences as a clinician, whether that's a continuing education course or being a CI, a clinical instructor for a student, I always say, like, sometimes those experiences are like mirrors. They tell you good things, like, okay, I'm really doing the work. I've got the knowledge base about lymphedema and all the elements of lymphedema and how I can intervene with lymphedema or whatever. But then sometimes it can also give you like a gut check of like, what have I been doing for the last, at least in relation to this podcast topic, for the last month? What have I been observing? What have I been doing? How have I been formulating my own thoughts, my own decisions as a clinician? And that can be challenging and be like, I was doing that all wrong. That's not how I felt, but I was like, there's a lot of work to be done. And how is my clinical practice, knowing the information I know now, going to change? How does it need to change? How do I need to, come to this lymphedema coalition meeting and talk about, well, if we're going to be a center of excellence, like, here's the gold standard. Well, how do we get the resources to make that more often than not what the patient can do? And there's still going to be situations where it's not possible. Maybe we need to get a little bit more creative, telehealth, or even the networks that you create in your lymphedema certification courses. Also, we had we did a spreadsheet and everyone filled out their information, their email, their contact information, even other areas that they like to treat. So for me, I'm like, yes, I'm a lymphedema therapist, but I really love oncology and return to sport. So everyone in my class knows that. And we had a PT who was doing a residency program. So it was already, two of them were doing residency programs. It was already intertwined into their curriculum and their residencies. Cool. And so we got that experience from them and connected with them. And then we had other therapists from other states, and some of them were across the country. And, so then it was like, okay, if I have a patient that's closer to West Virginia than they are Charlottesville, Virginia, I could refer to these two people that are in those locations. And maybe instead of driving 3 hours to see me, they can drive an hour to see someone else who is
Excellent.
just as capable
Excellent.
as me. And that's a way to break a barrier. And so it's also about like the networking piece, I think is really huge about the program. So then we can create this web of like, where are all the CLTs? Because that's another barrier, is access to people, access to trained therapists. That's why people have to drive so long,
Right.
to be seen.
Right.
And so it's like learning, where are your resources? Who are they? And I think that's another key piece of what the course really offers, is that you practice with these people, they critique you in positive ways, and then you stay connected with them. And if they have a patient that moves, or they have a client family member that lives in the area and now has breast cancer and needs lymphedema treatment, it's like, heck yeah, send my contact information. I'm happy to talk to them about getting them connected. So you also get to start connecting the dots, and that's a really creative way sometimes to break those barriers when it comes to specifically lymphedema management. But I definitely think we've got a long way to go across the board. And a lot of therapists are doing such good work with so little, which I think is just an applaud to them out there. Like, just keep doing what you're doing, getting creative, and meeting those patients where they're at, because we don't want to turn them away from a treatment that can really, really help them, and make a difference in their life, and get them to the things that really matter to them, through this treatment. And it may not have to take 5 days a week to do it. We may be able to accomplish it in shorter amounts of time. And I've seen that possible. So I think it also challenges what courses present. So I think that back and forth, between what we go in knowing and what the course present us, and what do we know now, that dialogue within ourselves and with other clinicians should never stop. Because I think it's super helpful. And I think even it brings up, great conversations in the cancer rehab community. I remember, I don't know, maybe a month after I finished the course, there was a PT on there was talking about, like something with like lymphovenous bypass surgery, which is another form of lymphedema management. A lot of times it's happened after someone's failed conservative management, but now current practice is starting to say, what if we do it at the time of surgery to affect someone's risk of development, which is, great. Heck yeah, let's do it. You're already there. Let's make it happen. And so, well, okay, they still have to, I've actually gotten to see one of those surgeries, which is pretty freaking awesome to see. It's a microscopic level. It's wild. It was really, really cool. I actually did that before I took the CLT course, like literally the Friday before I left work to drive down there. I got to see that surgery, got to observe it, and then went to the course, which was freaking awesome. And
that is so cool.
Someone in their hospital system was like, hey, they're starting to do this, and they're asking us to develop a protocol of like wrapping, and how much wrapping should we do? Kind of go full circle back to, the least amount we need to do at the right time to get the right results. And they were like, do I even teach them the herringbone pattern, or does the simple spiral suffice? And how many different bandages do I need to do if this person's just at risk? And we're just kind of prophylactically doing this to manage, one, postoperative swelling, but two, just manage their risk. And I'm like, and so I got to comment on that and be like, well, this is what my course told me. This is kind of what we're doing in our hospital system, as we're potentially moving in that route, and just having dialogue in the rehab community about, what are you guys doing? Oh, well, let me know when you have that published. Like, I want to read it. And so I think just sharing that stuff is so cool too. And now I have a knowledge base to have even more meaningful conversations with clinicians, which I think is really incredible.
I think that's one of the things I've really appreciated about being a certified lymphedema therapist, and having that knowledge of, having gone through a really intensive course to learn this information and to be able to walk out and treat patients. I've shared this previously, but there might be some new listeners. I took my CLT course in June of 2018, and then I sat for my licensure exam in July, and I started working in August of 2018. So I didn't practice doing those skills for about a month and a half to maybe like 2 months. And I still week 1 of when I started working with patients, I was extremely confident in my MLD and my bandaging skills to at least get the basics done. And I think that says a lot to the level of preparation that you will come out of that course with. And I cannot say that, I cannot speak enough praise for the level of intensity and how I came out of that course. And so I just commend those programs on that. Hey y'all, this is Elise. Sorry to interrupt your podcast, but Kelly and I had so much to talk about in this interview that we actually split up the episode into 2 because we literally kept going for an hour and 45 minutes and we had to draw the line somewhere. So just know that the second part of this episode is releasing next Tuesday on the dot. It will be dropped into your inboxes. It will be delivered to your podcast players. Side note, if you're not already subscribed to the OncoPT podcast, please make sure you do, because that is the best, fastest way to get all of your episodes in one convenient place. So know that part 2 is coming, but I'm going to make you wait until next week to listen to it. So thank you so much for listening. And until next time, this is Elise with the OncoPT. And remember, you are exactly the physical therapist that your patients with cancer need. So let's get to work.
Thank you so much for listening to this episode of the OncoPT podcast. If you'd like to help support the podcast, please share it with others, leave a rating and review, or support us on Patreon.